Good afternoon, our dear students. Today we continue a cycle of lectures for fourth year students, first semester or MA groups. And you remember that previous lecture, it was the last lecture in the cycle of endocrinology. I remind you that it was connected with hypothalamic pituitary system, and today we start a new submodule that connected with gastroenterology. It will be several lectures about GI disorders, and first of it is gastroesophageal reflux disease, and it is a topic of our today's lecture. But before I'm going to start, I want to remind you a little bit anatomy and physiology of upper part of GI or esophagus and stomach, because it was dramatically important for understanding the mechanisms, the pathophysiology, the way of diagnostics and treatment of these disorders. That's why let's return a little bit to anatomy and pathophysiology. On the picture you see an esophagus. It is a muscular tube, approximately here it was written 20, but it's nearly 40 centimeters in length, that connected pharynx and stomach just below the diaphragm. Its only function, it has just one function: to transport food from the mouth to stomach. The esophagus consists of three parts. It is cervical parts in a level of in cervical level, the thoracic part that placed in thorax, and abdominal, small abdominal part. The upper portion of the esophagus, both the outlet longitudinal lower and inner circular muscle layers, are striated. Yes, it's one type of muscles. In the lower two-thirds of esophagus, including thoracic and abdominal parts, they are containing a lower esophageal sphincter. Both layers are composed of smooth muscles. Upper third, it is striated muscles. Two lower thirds, it is smooth muscles. The distal thoracic esophagus is located on the left side of midline. As the thoracic esophagus enters the abdomen through the esophageal hiatus in the diaphragm, it becomes the abdominal esophagus. On a picture you see in a lower part it is small narrowing. This narrowing, it is we named lower esophageal sphincter or lower high pressure zone. It is a place of going through the diaphragm through the hiatus, and lower it is some small part of esophagus and before it goes to the stomach. The hiatus is formed by the right crus of the diaphragm, which forms a sling around the esophagus with the right and left pillars, so that the esophagus narrows when the diaphragm contracts. Yes, these mechanisms take function of sphincter or pressure or closing of esophagus. The actual contribution the diaphragm provides in maintaining the adequate length of intra-abdominal esophagus is not clearly understood. However, careful identification and approximation of pillars during surgical treatment is crucial for preventing recurrence of reflux disease. At this level, the phrenoesophageal ligament or membrane, phrenoesophageal membrane, which is the reflection of the subdiaphragmatic fascia onto the transversalis fascia on anterior abdominal wall, also encircle the esophagus and help function of diaphragm like sphincter. A prominent fat part located on the anterior surface of the esophagus marks the lower limit of the phrenoesophageal ligament, which corresponds to the esophagogastric junction. This junction lies in the abdomen and forms the angle of GIS. It have to be some angle. The acute angle and the length of abdominal esophagus both contribute to the normal closure of esophagus when intragastric and intra-abdominal pressure is high. It, like a valve, have to close esophagus not to return foods during high pressure intragastric or intra-abdominal, not returning food. We told one more time that esophagus is divided on cervical, thoracic, and abdominal parts. The esophagus made up of striated upper and outer longitudinal mesial layers. The proximal third of the esophagus is striated, which tranches to smooth muscle in distal 2/3. The proximal esophagus contains the upper esophageal sphincter, it can be upper too, which comprises the craniopharyngeus and thyropharyngeus muscles. The lower esophageal sphincter, or more actually the distal esophageal high pressure zone, is the distal-most segment of esophagus. It is nearly 3-5 centimeters in adults and can be anywhere from 2 to 5 centimeters in length. It, what I told you, place of going through the diaphragm. Maintenance of an adequate intra-abdominal high-pressure zone is crucial in preventing gastroesophageal reflux disease. This high-pressure zone does not correspond to any visible anatomic structure. It is a zone created by complex architecture of smooth muscle fibers, and it's typically identified during manometry. We can say that on this region it is high pressure zone. It is individual in each patient, and individually you can check it just according to intraesophageal manometry with catheter. You see the anatomy of this place of lower esophageal sphincter or lower high pressure zone. You see its structure on scheme on the picture. The esophagus is lined by striated squamous epithelium, which extend to the squamocolumnal junction when the esophagus joins stomach. Recognized as a zigzag zone or Z-line. Just above the most proximal gastric fold, the place of going from the esophagus to stomach because of different epithelium. This zone is visible on endoscopy, and this zone of changing of epithelium, it looks like not smooth, it is like zigzag line or Z-line. The esophagus is separated from the pharynx by the upper esophageal sphincter, which is normally closed due to tonic activity of the nerve supplying the craniopharyngeus. And you see interesting pictures, yes, the different images of that line. First picture, it is microscopic picture of changing epithelium with you see upper line, it is squamous epithelium and submucosa and musculars externa of esophagus, and submucosa contains blood vessels and lymphocytes. It is microscopic picture of this field. Second picture, you see endoscopic view. It is normal going from the esophagus to stomach, and its visible border between them that we named that line. And the last one, it is a macroscopic pathomorphological picture of esophagus which going to stomach. Esophageal physiology. To prevent the damaging of esophageal mucus, it presents physiologically some mucosal defense mechanisms. What mechanisms we normally have in esophagus? First of them, it is surface or mucus and unstriated water layer trap bicarbonate. This mechanism is a weak buffering mechanism compared to that in the stomach and duodenum. Next border and next defense, it is epithelium. The apical cell membranes in the junctional complexes between cells act to limit diffusion of H plus into the cells. In esophagitis, the junctional complex are damaged, leading to increased acid diffusion and cellular damage. Next mechanism, it is post-epithelium. It have a defensive function too. Bicarbonates here normally buffers acid in the cells and intracellular spaces. Hydrogen ions impair the growth and replication of damaged cells. One more mechanism, it is sensory mechanisms. Acid stimulates primary sensory neurons in the esophagus by activating the vanilloid receptor 1. This can initiate inflammation and release a pro-inflammatory substances from the tissue and produce pain. Pain can also be due to contraction and longitudinal esophageal muscle. Okay, during the swallowing, the bolus of food is voluntarily moved from the mouth to the pharynx. This process is mediated by complex reflex involving a swallowing center in the dorsal muscle nucleus in the vagus in the brainstem. Once activated, the swallowing center neurons send the pre-programmed discharges of inhibition, followed by excitation to the motor nuclei of the cranial nerves. This results in initial relaxation followed by distally progressive activation of neurons of the esophageal smooth muscle and low esophageal sphincter. It is a reflectory process of opening of sphincters. Pharyngeal and esophageal peristalsis mediated by this swallowing reflex causes primary peristalsis. Secondary peristalsis arises as a result of stimulation by a food bolus in the lumen, mediated by a local intraesophageal reflex. Tertiary constructions indicate pathological non-propulsive contractions resulting from aberrant activation of local reflexes within the myenteric plexus. The smooth muscle of thoracic esophagus and lower esophageal sphincter is supplied by vagal autonomic motor nerves consisting of extrinsic preganglionic fibers and intramural postganglionic neurons in the myenteric plexus. There are parallel excitatory and inhibitory pathways, and their balance lead to normal peristalsis. Etiology of gastroesophageal reflux disease. Yes, I told you a lot about physiology, about normal tonus, about closing of esophageal sphincter, about normal peristalsis. When it disturbed, one of the most probable situation, it when contents of stomach returns to the esophagus. It is a most probable pathology, and we name this disease gastroesophageal reflux disease. What the etiology of it? Here on the picture you see the most probable causes. It is low stomach acid. It is too much gas in the abdomen with increasing intra-abdominal pressure. It presents some GI parasites. One of the most often problem, it is hiatal hernia, What else? The pregnancy, the obese, the tight-fitted clothing, wrong posture, larger meals, cigarette smoking, medications, H. pylori, too much exercise, magnesium deficiency, and low chloride diet, all of them can lead to can be risk factor or direct etiology of gastroesophageal reflux disease. And the most often it manifests like on picture 2 when it is present some factors like iatrogenic factors, using alcohol, drugs, previous surgery, or for example PATHOPHYSIOLOGY strictures. Moreover, it is bad habits like large meals, it is some concomitant disorders like for example coughing, and with all other factors, usually this disorder is multifactorial. All of them lead to not enough closing of low esophageal sphincter, it is not enough, not normal peristalsis, and lead to returning or regurgitation of stomach contents to the esophagus. Pathophysiology of gastroesophageal reflux disease. The lower esophageal sphincter, I remind you, we can find it just with manometry. It is a zone of elevated intraesophageal pressure, and usually it placed on esophagogastric near the esophagogastric junction. For proper lower esophageal sphincter function, this junction may be located in the abdomen so that the diaphragmic crura can assist the action of low esophageal sphincter, thus functioning as an extrinsic sphincter. In addition, the lower esophageal sphincter may have a normal length and pressure and a normal number of episodes of transient relaxation. A transient relaxation, it is relaxation in the absence of swallowing. It can be three dominant mechanisms of esophagogastric junction incompetence. First mechanism, it is transient low esophageal sphincter relaxation. It is a vasovagal reflex in which low esophageal sphincter relaxation is elicited by gastric distension. Yes, it can be open reflectory, not hernia, it's not problem with low esophageal sphincter, but reflectory, according to abnormal innervation, it can be opened. Second mechanism, it is low esophageal sphincter hypotension or dysfunction of the sphincter. And third one, it is anatomic distortion of the esophagogastric junction inclusive to hiatus hernia. Of note, the third factor, esophagogastric junction anatomic disruption, is both significant unto itself and also because it interacts with the two first mechanisms. And you see this picture the same with previous. Usually it leads to symptomatic, most often like heartburns. Another important moment in pathophysiology of gastroesophageal reflux disease. Delayed gastric emptying. The postulated mechanism in which delayed gastric emptying may cause gastroesophageal reflux disease is an increase in the gastric contents resulting in increased intragastric pressure and ultimately increased pressure against the lower esophageal sphincter. This pressure eventually defeats the lower esophageal sphincter and leads to reflux. However, objective studies have produced conflicting data regarding the role of delayed gastric emptying in the pathogenesis of gastroesophageal reflux disease. Mechanism in hiatal hernia, pathophysiological. The lower esophageal sphincter may migrate proximally into the chest and lose its abdominal high pressure zone. It is incompetence of the sphincter. Or the length, for example, of high pressure zone may decrease. The diaphragmatic hiatus may be widened by large hernia, which impairs the ability to the crura to function as the external sphere. You remember the diaphragmatic crura press the esophagus and make function of esophagus. In case of hernia, it goes upper with a part of stomach. That's why this junction is not obstructed. It widened, and without this sphincter, gastric contents can, without sphincter, returns regurgitate to esophagus. Finally, gastric contents may be trapped into the hernial sac and reflux proximately in the esophagus during relaxation of lower esophageal sphincter. Reduction of the hernias and crural closure are critical to restoring an adequate intra-abdominal length of esophagus and recreating of high-pressure zone. Symptoms of gastroesophageal reflux disease. GERD, or gastroesophageal reflux disease, is associated with a set of typical or esophageal symptoms, including heartburn, regurgitation, and dysphagia. In addition, these typical symptoms, abnormal reflux, can cause atypical or extraesophageal symptoms, such as coughing, chest pain, and wheezing. A history of nausea or regurgitation should alert the physician to evaluate for delayed gastric emptying. Physical examination of patient with gastroesophageal reflux disease. What typical symptoms are we trying to find during physical examination? First, it is heartburn. It is the most common typical symptoms and the most common complaint of the patient with a gastroesophageal reflux disease. It is felt like a retrosternal sensation of burning or discomfort that is usually occurs after eating or when lying supine or bending over. Regurgitation is an effortless return of gastric or esophageal contents into the pharynx. Patients usually feel this returning. Regurgitation can induce a respiratory complication if gastric contents spill into the tracheobronchial tree. Next symptom, it is dysphagia. It occurs approximately 1/3 of patients with dysphagia experience a sensation that food is stuck, particularly in the retrosternal area. Dysphagia can be an advanced symptom and can be due to primary underlying esophageal motility disorder, a motility disorder secondary to esophagitis or stricture formation. And here you see a table with description, the heartburn with the reflux and regurgitation, what the difference between them. Atypical or extraesophageal symptoms, I told you they are including coughing or wheezing. There are respiratory symptoms resulting from aspiration of gastric contents into the tracheobronchial tree from the vagal reflex arc producing bronchoconstriction. Approximately half of patients who have GERD-induced asthma do not experience heartburn. Next extraesophageal symptom, it is hoarseness. It results from irritation of the vocal cords by gastric refluxate, and it's often experienced by patients in the morning. Next, it is a reflux. It is the most common cause of non-cardiac chest pain, accounting for approximately half of cases. Patients can present to the emergency department with pain resembling or a myocardial infarction. Reflux should be ruled out using esophageal manometry and 24-hour pH testing if necessary, once a cardiac course of the chest has been excluded. Additional atypical symptoms, they are a little bit more rare but possible too. They range from abnormal reflux, include damage of the lungs like pneumonia, asthma, idiopathic pulmonary fibrosis. It can be vocal cords like laryngitis or cancer. It can be ear problems like otitis media and teeth problems like enamel decay. Okay, is there for all patients are indications for endoscopy or upper endoscopy? Let's discuss. Upper endoscopy is not required in presence of typical GERD symptom in heartburn or regurgitation. It's from up to date. Not all typical patients with typical symptoms of GERD, you don't need for upper endoscopy. Just clinical examination and additional non-invasive test is enough for you to put diagnosis and start treatment. Upper endoscopy is recommended if diagnosis of gastroesophageal reflux disease is unclear or evaluate alarm features or abnormal imaging is not performed within the last 3 months. Upper endoscopy should also be performed to screen a Barrett's esophagus in patients with risk factors. Patients with GERD should receive empiric acid suppressive therapy, even if additional evaluation with an upper endoscopy is indicated. Endoscopy is a sensitive test for diagnosis of esophagitis, but it will miss non-erosive reflux disease since some patients have symptomatic reflux without esophagitis. The most sensitive test for diagnosis of gastroesophageal reflux disease is 24-hour ambulatory pH monitoring. Endoscopy is indicated in patients with reflux symptoms refractory to anti-secretory therapy. In those with alarm symptoms such as dysphagia, weight loss, or GI bleeding, and in those with recurring dyspepsia after treatment that is not clearly due to reflux on clinical grounds alone. Endoscopy should be considered in patients with long-standing more than 10 years gastroesophageal reflux disease, as they have a 6-fold increased risk of hair-boring Barrett's esophagus. I will show you what is that. Compared to patients with less than a year of reflux symptoms. Here on the scheme you see how performed usually upper endoscopy, how looks endoscope. Esophagogastroduodenoscopy or upper endoscopy demonstrates the anatomy and identifies the possible presence of severity of complications of reflux disease, like esophagitis, Barrett's esophagus, and strictures. Using the patient's history and pathologic analysis of biopsy specimens obtained during endoscopy, the diagnosis of gastroesophageal reflux disease can be made. Endoscopy also excludes the presence of other diseases like peptic ulcer that can be present similarly to reflux disease. Another method of investigation of patient with GERD, it is esophageal manometry. Esophageal manometry defines the function of lower esophageal sphincter and esophageal pressure. Esophageal manometry is essential for correctly positioning the probe for 24-hour pH monitoring. You can't fix pH monitor without manometry because you need this specific high pressure zone, and I remind you, it placed individually in each patient. Indications for esophageal manometry and prolonged pH monitoring. It is persistence of symptoms while taking adequate anti-secretory therapy, such as PPI. If we give PPI, they are ineffective or not enough effective, we should do manometry with pH monitoring. Next indication, it is recurrence of symptoms after discontinuation of acid-reducing medications. Next, it is investigations of atypical symptoms such as chest pain or asthma in patients without esophagitis, and confirmation of the diagnosis in preparation for anti-reflux surgery. Okay, what is ambulatory 24-hour pH monitoring? It looks like this, like on this picture. It is a small monitor with catheter that intranasally placed to the esophagus, and its distal end fixed in high pressure zone that we detected with manometry. This monitoring is criteria standard in establishing a diagnosis of gastroesophageal reflux disease with sensitivity of 96% and specificity of 95%. Very high informative test. It quantifies the gastroesophageal reflux and allows a correlations between symptoms of reflux and episodes of reflux. Patients with endoscopically confirmed esophagitis do not need pH monitoring to establish diagnosis of gastroesophageal reflux disease. The principal indications are to document excessive acid or non-acidic reflux, to correlate symptoms with reflux episodes, to identify candidates for anti-reflux surgery, and to evaluate the effectiveness of medical or surgical treatments. Ambulatory pH monitoring can be done when the patient is on or off portion pump inhibitor therapy or PPI therapy. When the test is done off therapy, the diagnosis of GI reflux disease can be confirmed or excluded. If monitoring is done off therapy and non-acidic pH is found in the stomach, the diagnosis of achlorhydria is confirmed. Monitoring on therapy can determine the adequacy of gastric acid suppression and the presence of esophageal acid exposure in patients who have been referred for testing because PPI therapy failed. Tests may use transnasal continuous reflux monitoring catheter or wireless pH monitoring device that is endoscopically attached to the distal esophagus. Nuclear imaging. Gastric emptying studies may be performed in patients with delayed gastric emptying and believed to contribute the manifestation of gastroesophageal reflux disease symptoms. Gastroesophageal reflux scintigraphy or nuclear imaging can be performed with acidified orange juice labeled to technetium 99. Sulfur colloid. Compared with fluoroscopy, this allows for a longer time of evaluation, a decreased radiation dose, and ability to semi-quantitative an amount of reflux. However, a gastroesophageal reflux scintigraphy has a little role in adult patients because of limited sensitivity and the availability of other methods of evaluation. Gastroesophageal reflux scintigraphy is much more commonly used in infants and children because of non-invasive nature of the study and relatively low radiation dose. In infants and children, the study is often performed with labeled milk. In addition to evaluating the degree of reflux, pulmonary aspiration can be detected by imaging over the lungs. Scintigraphic studies are neither sensitive nor specific for the diagnosis of gastroesophageal reflux disease. Radiography or X-ray. Plain radiographic findings are usually not informative for evaluation patient with gastroesophageal reflux disease, but they are very helpful in evaluating pulmonary status and basic anatomy. In combination with simplicity and cost of this methodic, it is a very good method that we usually prescribe to all patients. Chest images may demonstrate a large hiatal hernia, but small hernias can be missed easily. Upper GI contrast-enhanced studies are the initial radiologic procedure of choice in the workup of the patient in whom gastroesophageal reflux disease is suggested. The primary use of upper GI contrast-enhanced studies is suspected reflux is to evaluate anatomy and not to detect reflux, as sensitivity is limited in patients with known esophagitis and normal controls can leave visualized reflux. Drinking 15-30 milliliters of ice water can improve sensitivity and specificity for reflux. Barium esophaggrams, as you see on the pictures, it is contrasted esophagus. Oswallows are helpful for identifying structural abnormality of the esophagus and esophageal keratose, which include esophageal rings, strictures, and ulcer, and keratal hernias. Approach considerations for a patient with gastroesophageal reflux disease. Treatment of gastroesophageal reflux involves a stepwise approach. The goals of treatment are to control symptoms, to heal esophagitis, and prevent recurrent esophagitis or other complications. The treatment of it based on lifestyle modification and control of gastric acid secretion through medical therapy with antacids or PPIs, or surgical treatment with corrective anti-reflux therapy. Let's discuss more. Lifestyle modifications. They include following here. They are very important in some patients, especially pregnant. It is a first choice therapy. It is obligatory for all other patients because other ways of treatment does not exclude lifestyle modification. They are necessary for effectiveness of treatment. Important moment here. If patient is overweight, it is obligatory losing weight. It is avoiding alcohol, chocolate, citrus juice, and tomato-based products. Also suggest avoiding peppermint, coffee, and possibly the onion family. Avoiding large meals. It is important because large meals increase pressure of stomach and can provoke regurgitation. It is waiting 3 hours after meal before lying down, and elevating of head of the bed by 8 inches. Lifestyle modification are the first line management what I told in pregnant women. Advise patient to elevate the head of the bed, avoid bending or stooping position, eat small frequent meals, and refrain from digesting food except liquids within 3 hours after bedtime. Pharmacological therapy and the first line therapy, it is, I told a lot, PPI or proton pump inhibitors. PPIs are the most powerful medications available for treating of gastroesophageal reflux disease. These agents can affect the conditions has been objectively documented. Available PPIs include omeprazole, lansoprazole, rabeprazole, esomeprazole, and additionally on the picture you can see pantoprazole and dexlansoprazole. Proton pump inhibitors inhibit gastric acid secretion by inhibition of the Kali-H-etaphase enzyme systems in the gastric parietal cells. Long-term use of these agents has also been associated with bone fractures in postmenopausal women, chronic renal disease, acute renal disease, community-acquired pneumonia, and Clostridium difficile intestinal infections. Best practice recommendations to proven GERD consist of long-term therapy with the lowest dose of PPI that provides symptoms control or healing of esophagitis. PPI are recommended as a first-line drugs in treatment of GERD. Next group, it is H2 or histamine 2 receptor antagonists. A mechanism of its action, they competitively inhibits H2 receptors of parietal cells in the stomach. Pharmacological effects. It is inhibition of gastric acid secretion, decrease an amount of pepsin secretion, anti-ulcer effects, heals gastric and duodenal ulcer. Incidence of serious side effects is very low for them. The drugs here, it is this group include cimetidine, famotidine, nizatidine, and ranitidine. Next group, we name it antacids. What is that? Antacids are basic aluminium, calcium, or magnesium compounds, primary affecting intermediate esophageal symptoms, particularly heartburn. Their main advantage is rapid relief of symptoms. Antacids is not provide prolonged symptom relief, heal erosive esophagitis, or prevent GERD complication. It's just the local action. One more time, mechanism. They promote gastric mucosal defense mechanism, and they affect secretion of mucus with protective barrier against acid. Secretion of bicarbonate that helps buffer acidic properties. And prostaglandins that prevent activation of proton pump, which result in decreasing of acid production. Next group that can be used in gastroesophageal reflux disease, it is prokinetic agents. They affect the intestinal motility that can be delayed. Gastric emptying has been identified in some patients with gastroesophageal reflux disease. It follows that prokinetic agents may be of benefit in such patients. The newer generation of 5-HT4 selective agonists like procalopride, which does not have a cardiovascular toxicity of cisapride and other groups, may prove effective for GERD, but it's just investigated. Clinical trials are lacking, they are not finished. That's why waiting for better drug. For today, the most usable drug is metoclopramide. They are effective, but only in patients with mild symptoms. Other patients usually require additional acid-suppressing medication like PPIs. The usual regimen in adults is metoclopramide 10 mg daily. Long-term use is not recommended because they may have a serious, even potentially fatal complications. Okay, surgical care or anti-reflux surgery. The operation named fundoplication. Indications for it include following: patients with symptoms that are not completely controlled by PPI therapy can be considered for surgery. Surgery can also be considered in patients well-controlled GERD who desire definitive one-time treatment. The presence of Barrett esophagus as an indication for surgery, wherever acid suppression improves the outcome or prevents the progression of Barrett esophagus, remain unknown. But most authorities recommend complete acid suppression in patients with histologically proven Barrett esophagus. The presence of esophageal manifestation of GERD may indicate the need for surgery. These include the following. First, respiratory manifestation like a cough within aspiration, ear, nose, and throat manifestation like, for example, hoarseness, sore throat, otitis media, and dental manifestation, for example, enamel erosion. Moreover, the indications for surgery can be a young age of patients, poor patient compliance with regard to medications. Hope you know what is compliance. It is postmenopausal women with osteoporosis, patients with cardiac conduction defects, and cost of medical therapy. I told you that we named this operation fundoplication. Mostly it conducted laparoscopic through the laparoscopy. It performed under general endotracheal anesthesia. 5 small from 5 to 10 millimeters incisions is used. You can see it on image. The fundus of the stomach is wrapped around the esophagus to create a new valve in the level of esophagogastric junction. You see it schematically here. The essential elements of this operation is to complete mobilization of fundus of the stomach with division of the short gastric vessels. After it, reduction of hiatal hernia. after its narrowing of esophageal fundus and after its creation of complete 360% funduplication over larger intraesophageal dilator. We name this operation by author Nissen funduplication. Laparoscopic funduplication procedure takes about 2 to 2.5 hours. Hospital stays approximately 2 days. Patients resume regular activity within 2-3 weeks. And this operation is quite effective. Approximately 92% of patients obtain resolution of symptoms after undergoing laparoscopic funduplication. And algorithm of medical management in GERD. I will not stop on it, detailized it. Here systemically I show you approach to the patient. Is it present or no present symptoms? Is it present alarm symptoms? And what strategies in treatment we use for all these patients. And this scheme a little bit more detailized for medical ways and surgery ways of treatment according to symptoms and results of investigation. What strategy of treatment? Is it surgical? Is it pharmacological? And what pharmacological ways we can use for patients depending on their clinical picture. Differential diagnosis of gastroesophageal reflux disease includes coronary artery disease, achalasia, eosinophilic esophagitis, non-ulcer dyspepsia, rumination syndrome, esophageal diverticular, gastroparesis, esophageal and gastric neoplasm, and peptic ulcer disease. All these disorders can have nearly the same clinical picture. That's why we should differentiate them from other gastroesophageal reflux disease. Complications can include erosive esophagitis. It characterized by erosions or ulcers in the esophageal mucosa. Patients may be asymptomatic or can present with worsening symptoms of gastroesophageal reflux disease. The degree of esophagitis is endoscopically graded using the Los Angeles esophagitis classification system, which employs the A, B, C, and D grading system, based on variables that include length, location, and circumferential severity of mucosal break of the esophagus. Next complication, it is esophageal strictures. Chronic acid irritation of distal esophagus can result in scarring of distal the esophagus, leading to the formation of the peptic stricture. Patients can present with symptoms of esophageal dysphagia or food impaction. Los Angeles guidelines recommend esophageal dilation and continue PPI therapy to prevent the need to repeated dilation. Barrett's esophagus. Its complication occurs as a result of chronic pathological acid exposure to the distal esophageal mucosa. It leads to a histopathological change of the distal and esophageal mucosa, which is normally lined by stratified squamous epithelium to metaplastic columnar epithelium. Barrett's esophagus is more commonly seen in Caucasian males above 50 years. Obesity and history of smoking and predisposes to the development of esophageal adenocarcinoma. Current guidelines recommend the performance of periodic surveillance endoscopy in patients with diagnosis of Barrett's esophagus. Okay, a little bit more about esophagitis, like complication of GERD. Esophagitis or esophageal mucosal damaging with inflammation, it is a complication of GERD occurring approximately in 50% of patients. A best defined subset of GERD patients, albeit a minority overall, have esophagitis. Esophagitis occurs when refluxed gastric acid and pepsin cause necrosis of the esophageal mucosa, causing erosions and ulcers. Note that some degree of gastroesophageal reflux is normal, physiologically intertwined. Esophagitis may be diagnosed using endoscopy, although it can't always be appreciated on endoscopy. As many as 50% of symptomatic patients with gastroesophageal reflux disease demonstrate no evidence of esophagitis on endoscopy. Still, documentation of this complication is important in diagnosing gastroesophageal reflux disease. Degrees of esophagitis are described by Severi-Miller classification. You see it as follows. Grade 1, it is erythema. Grade 2, according to Severi-Miller, it is linear non-confluent erosions. Grade 3, it is circular confluent erosions. And grade 4, it is strictures or Barrett esophagus. One more time, please fix for yourself this Severi-Miller classification of esophagitis. Okay, here you see endoscopic view of esophagitis. On picture A, it is grade A. One or more mucosal breaks, you see it by the arrows, no longer than 5 mm that do not extend between the tops of two mucosal folds. You see grade A on picture 1. Picture 2, it is grade B. One or more mucosal breaks longer than 5 mm that do not extend between the tops of two mucosal folds. Picture C, it shows us grade C. One or more mucosal breaks that are continuous between the tops of two or more mucosal folds but involves less than 75% of the circumference. And stage or grade D on picture D, it when one or more, here you see 3 mucosal breaks, it's shown by arrows, that involves at least 75% of the esophageal circumference. All endoscopic pictures of each grade you can see here. Stricture. Strictures are advanced form of esophagitis and connected with circumferential fibrosis due to chronic deep injury. Strictures can result in dysphagia and short esophagus. Esophageal reflux strictures typically occur in the mid to distal esophagus and can be visualized on upper GI tract studies and endoscopy. Presence of a stricture with a history of reflux can also help diagnose gastroesophageal reflux disease. Patients present with dysphagia to solid meals and vomiting of non-digested food. As a rule, the presence of any esophageal stricture is an indication that patient needs surgical consultation and treatment, usually surgical consultation. When patients present with dysphagia, barium esophagography is indicated to evaluate for possible stricture formation. In these cases, especially when associated with food impaction, eosinophilic esophagitis may be ruled out prior to attempting any mechanical dilation of the narrowed esophageal region. Next complication, it is Barrett's esophagus. You can see here funny pictures about it. It is the most serious complication of long-standing and severe gastroesophageal reflux disease. It is a development of Barrett esophagus is present in 8 to 15%. It is quite often with GERD. Barrett esophagus is thought to be caused by a chronic reflux of gastric juice in the esophagus. It is defined by metaplastic conversion to the normal distal squamous esophageal epitheliums to columnar epithelium. Histologic examination of esophageal biopsy specimen is required to make a diagnosis. Varying degrees of dysplasia may be found on histologic examination, like Barrett esophagus with intestinal type of metaplasia has malignant potential and is the risk factor for development of esophageal adenocarcinoma, increasing the risk of adenocarcinoma in 30-40 times. Such a danger is complication. Here you see First picture with risk factors for GERD, esophagitis, and Barrett's esophagus, and second it is you see metaplasia from good squamous esophagus epithelia to metaplastic epithelia in the esophagus gastric junction on that line. The diagnosis of Barrett esophagus showing proximal displacement of a squamo-columnar mucosal junction and biopsies demonstrating columnar lining above the proximal gastric folds. Intestinal metaplasia is no longer a requirement of the British Society of Gastroenterology definition, but is central in the American College of Gastroenterology guidelines. Barrett's esophagus may be seen as a continual circumferential sheet or finger-like projections extending upwards from the squamo-columnar junction, or as islands of columnar mucosa interspersed in areas of residual squamous mucosa. Signs and symptoms are unspecified. Of it. The signs and symptoms: it is frequent heartburn and regurgitation of stomach contents, difficulty swallowing food, less commonly chest pain. It is typical for esophagitis, but we understand that it can result in Barrett esophagus. If low-grade dysplasia is found on endoscopic surveillance, a repeat endoscopy with chondritic biopsies every 1 cm is usually performed within 6 months. While the high-dose proton pump inhibitors, long-term surveillance in this group is controversial. If high-grade dysplasia is found, this is usually in the contents of endoscopically visible lesion, which is, if nodular, is removed by endoscopic mucosal resection for more accurate histological staging. If high-grade dysplasia is detection in the absence of any endoscopically visible lesion, high-dose PPI is started and repeat biopsy taken within 3 months. Endoscopic ultrasound is frequently used to more accurately stage this patient group to exclude cancer and associated significant lymphadenopathy. Radiofrequency ablation has a superseded photodynamic therapy as a technique of choice for endoscopic treatment of dysplasia within Barrett's segments following removal of any nodular lesions, returning to the esophagus to squamous lining. The benefit of radiofrequency ablation in low-grade dysplasia is currently under evaluation. Now it is investigated widely. And for today, that's all. Thank you for attention for my lecture. I hope it was interesting starting of gastroenterology cycle, and see you in 1 week in next lecture about gastroenterology. As usual, if you have questions, if you have some difficult moments, you can write your questions in the comments under the video and optimally in our closed Facebook page, and there we always are ready for discussion and will be glad for feedback from you. As usual, I ask all students who listen in lecture leave a name and group numbers in comments under the video. And now it is that's all. Goodbye and good luck. See you in 1 week.